Just give me a second.
Yes,
I just
sir.
आप है ना? तो अनुपम सर भी हैं क्या? हाँ.
Yes, sir. सर अनुपम सर नहीं आएंगे सर.
Okay. Anyone from the Delhi IAP? Or should I start?
No, sir. I think we should start, sir. किसी ने login नहीं किया.
Okay. So is the sound okay? We can hear beneath you quite
Yeah,
good.
sir.
Is the sound okay? It's
Yes,
fine,
sir.
na?
Yes, sir.
Okay.
Yes. आप लोग start
Okay.
कर दीजिए,
That's
sir.
fine. Okay. Fine. So, so good evening, everyone. And it's my personal pleasure to invite you, Dr. Vineet Wankare, today for a very important and very interesting topic of localization in different CNS infections. Normally, we hear about localization for the hemiplegia, localization for different kinds of like CNS deficits. But this is very interesting about how to localize. That's a very interesting topic. And on a personal note, Dr. Vineet Wankare has a very distinguished career and graduating and post-graduating in pediatrics, and thereafter having the whim of pediatric neurology. And he's our national secretary and a very dynamic one. He has really led the European society to a newer heights, spreading all across India. So, Dr. Vineet, over to you, and we all are eager to listen about this interesting topic.
Thank you. Good evening, everyone. At the outset, I want to thank the Delhi IAP and all the organizing people who have invited me for this talk. And thank you, Praveen sir. He's just like my elder brother. So, and for that kind introduction. So thank you so much for sharing the platform with you. So it's a privilege and honor for me. So topic is localization and differentials in the CNS infection. So you all know that the CNS infections are very common. Almost 1.2 million children suffer from CNS infection, and that's why we need to have an update and we need to develop our skill. PISU admissions these days, almost half, 50% of them do have some kind of CNS involvement. And eventually you must know what are the possible steps to reach out to the diagnosis. Having said that, there is a change in the paradigm shift in the acute encephalitis syndrome. This is a wonderful paper by our senior colleague, pediatric neurologist, Dr. Vidisha Banerjee from Bangalore, who talks about the changing paradigm. Earlier, used to have an infective causes of acute encephalitis syndrome. However, we have a lot of non-infective causes which are getting increased. If you compare 10 years back and now, I don't, so there are a lot of debates about it, whether they were existent and we are diagnosing it now, or it has really in the search. So there's debate going on, but it's definitely we missed out a lot 15, 20 years back, but now we know that this is there. So a lot of non-infective causes are on the rise. The art of neurological diagnosis always lies in observation. Look at the child as a whole. Don't look at the one thing. Spend good time with them. Observe his movements, responses, note down the consciousness. And every day when the child is admitted, ask about the speech, feeding, swallowing, bladder, bowel complaint. It is newly occurring and what is happening to the existing symptoms. That is something which is very important to know whether it's getting complicated, whether it's worsening or it's improving. Monitor the progress and appearance of signs and symptoms. So we need to have a sound knowledge of neuroanatomy because localization is something first about the anatomical localization. So otherwise, if you ask me how to diagnose a neuroinfection, we should have a clinical diagnosis. We make a presumptive diagnosis. Then we take a help of laboratory to make some important studies. And third is neuroimaging because the MRI is getting advanced in multiple possible ways. And these all things help us in diagnosing. So what are the steps for the diagnosis? Usually, if I go to any medical college or the second tier city and ask about a possible scenario of acute encephalitis syndrome, and I ask, what is your diagnosis? Usually they talk about the etiological diagnosis, like this can be a case of cerebral malaria or a viral encephalitis or something like that. I think we should avoid temptation to coming to an etiological diagnosis because there are proper steps of getting a diagnosis. You need to have define the anatomical terrain which is involved, the pathological process which is set in, and the etiological diagnosis should come as a third part, because that is the systematic way of getting a diagnosis. And I'll try to prove from my cases that how we should go ahead. So if you ask me what is a pragmatic approach, how should we reach to the anatomical diagnosis? The symptoms and the signs tells about the anatomical involvement. Like if you have seizures, it's from the gray matter. If you have motor deficits, it's from the white matter. If you have ataxia, if you have nystagmus, it's from the cerebellum. So signs and symptoms tell us the anatomical diagnosis. How the symptoms have a temporal correlation, and how the radiological features will tell us what is the probable pathology. How it has started, the onset, the progression of the symptoms, which comes first, which come later. So seizures followed by encephalopathy, your pathology is different. The encephalopathy followed by seizures, your likely pathologies are different. The third thing is epidemiology. So it has, every case has to be defined in terms of whether it has come as a sporadic or epidemic. What is the primary focus? Lungs के infection के बाद CNS manifestation हुआ कि starting में हुआ? Syndromic approach, whether they are purely CNS symptoms or CNS plus extrasystemic features, like a lot of patients have rash or pancytopenias or hepatomegaly. So if you have only CNS features, or if you have in addition CNS features, that will tell us what can be etiology. Radiological pattern supported by a specific laboratory test defines an etiology. So let's see with this, how can make a diagnosis in each case. So if you ask me, and it because I'm going to ask you the anatomical diagnosis, you can write in the chat box. So if you want to divide the brain into 5 major parts, which are there? The first one is the cortical gray matter. Usually, what are the pathologies affecting it? Is a focal encephalitis, like HSV is a prototype one. Second is a deep gray matter, which is combined of the thalamus and the basal ganglia. What are the prototypes pathology etiologies? Is J virus or acute necrotizing encephalitis. Third is a white matter, which can be subcortical or periventricular. Usually the demyelinating disorders like ADEM, MOG, NMO, they present with a white matter involvement. Fourth is a cerebellum, which usually varicella cerebellitis, ADEM is very well known. And the fifth part is brainstem. Rabies or Bickerstaff are the classic examples. So 5 parts of the brain: cortical gray matter, deep gray matter, white matter, cerebellar, or brainstem. So whenever you are localizing anatomical, it has to be one of this 5. So at least you should able to make after this presentation, then the purpose is solved. Then the purpose is solved. Let's learn the basics of neurology. I think we'll skip through this. So it helps in the diagnosis, not only differentiating etiology, but ensure what is identification of complications, and it also guides in the treatment of CNS infections. And you all know about the axial section, coronal sections in the sagittal. I think this much we have learned in our PG days. But what is most important for the PGs to understand, or the practicing pediatrician to understand, there are 4-5 sequences which are very important. T1 is basically which anatomy is affected. What could be the pathology is usually best identified on T2. If your differentials are inflammatory pathologies like encephalitis or infective granulomas, you must give a contrast. So contrast also is there is an inflammatory pathology or not. And then fourth thing is a diffusion weighted, where you find out the vascular supply to the wart is intact or not. So you require a DW and ADC for this. So these are the basic sequences of MRI you should be aware of. And as I told you, you should able to know. So can you see the cursor? So this is a cortical gray matter. And then you have a white matter, which looks white, black on this T1. And then you have deep gray matter, which is composed of the caudate and the basal ganglia, and then the thalamus, which looks like this. So at least this much part of the brain, and then the gray matter and the white matter. So you all know the things. And this is how your internal nuclei look like. So this is a caudate, this lentiform, and thalamus is already shown. So you just fix this picture, because I'm going to ask you questions in the subsequent cases where that part of the brain will be affected. And then you are going to make a diagnosis on the basis of the radiological patterns. So what is viral neurotropism is all about? Because the viruses have a selective affinity to some part of the brain. They selectively go there, damage the part of the brain, and form a radiological pattern, which you can also see on MRI. So that also helps in diagnosing that condition. So viral neurotropism is that affinity. So if you have a predominantly cortical gray matter and affecting the temporal lobe, what you're going to suspect is HSV. If you're deep gray matter, then what could be the cause? It can be a JE virus or dengue or varicella or Epstein-Barr or the respiratory syncytial. If you're predominant white matter, have you seen a child with a newborn, sudden unexplained encephalopathy or sepsis, everything is negative, and then you have a white matter, very bad hyperintensities, which are bilaterally symmetrical. Your causes is human paracovirus, and if it is a posterior pattern, it's rotavirus. So that if you don't know about this patterns in specifically neonates and these fixed etiologies, you can miss those diagnoses because treatment is IVIG. It's not the current conventional treatment. Rhomencephalitis, enteroviruses which affect the rhomencephalon, and then you have a rotavirus, Epstein-Barr virus, which affects the cerebellum. Your myelitis patterns into enteroviruses or JAB or some myelitis patterns. So at least this much basic patterns you should be aware, and you must know what is viral neurotropism is all about. And these are all the pathologies which affect there are interface pathologies like HI, infective granulomas, which selectively has affinity for that part of the brain. There are cytotoxic vascular edema because of the viruses in the gray matter, the demyelination at white matter, vascular territories, which is stroke or the vasculitis, cerebellar, brainstem, and spinal cord. So how you make, so okay, you made a diagnosis of anatomical pattern on the basis of the neurotropism, on the basis of the signs and symptoms. How you reach to the pathological diagnosis, that all depends on the temporal correlationships. If it is an hyperacute event, which occurs in minutes to hours, then it has to be a vascular, either ischemic hemorrhagic, or it can be an hypertensive one, trauma or toxins. Second is if it is acute from 24 to 7 days, 24 hours to 7 days, it should be more or like it's likely to be more infective. It has to be inflammatory, more infective. It can be vasculitic, metabolic, endocrine. And if it is subacute from 8 days to 15 days, it's usually the chronic infections like TB entry, and it can be autoimmune vasculitis and malignancy. So those are your possible pathological differentials if the symptom is subacute, has a subacute course. So let's see the case, because we are all clinicians and we learn a lot when we have active cases. So this is a 14-month-old boy admitted with fever, irritability, refusal to food since 2 days. Child is very irritable, like on in the mother's lap whole day. Toxic child, lethargic. I checked the signs, so there were no meningeal signs, DTR breast, extensive plantar. So my question to all of you, if you're 14-month-old with this kind of toxicity, irritability, with a change in the sensorium, will you call it as a meningitis even if you don't have a signs of meningitis or not? So the answer is yes. It still may have, it can be a meningitis because in infancy, you may not have the signs of meningism. So we did an LP, can be 5, it was 550, sugars were 25, proteins 120. So what is encephalitis and what is meningitis? At least this much you must know. When there's inflammation of the meninges, usually manifested in the form of severe headache, neck stiffness, photophobia, fever with alteration of sensorium, which usually comes little late because it's not an active parenchymal disease. However, in encephalitis, the alteration of the sensorium usually comes first. The focality of the seizures. As you have seen, most of the viruses as a focus, it selectively goes to the temporal part or some part. So usually the seizures comes first. If you may have focal neurological deficits, you may have fever, confusion, and that's how we initially categorize into these two types. But as I told you, the absent meningeal signs is not the criteria that which is not meningitis, because it may be present in infants, partially treated meningitis, severe malnutrition. If you're immunocompromised child or any, for that matter, any sick child, you may not have meningeal signs. So usually we keep a very low threshold for doing a lumbar puncture, especially in infants. That is something which you must aware, and rest of the things you all know. So as I told you, so there just beneath the skull, there is a subarachnoid. So there is a dural space, and then you have arachnoid and subarachnoid space. So usually if your meninges are inflamed, those are the signs of meningitis. So toxic look and intense neutrophilia usually suggest a bacterial pathology. Focus of viral infection may suggest your bacterial etiology. So signs of meningitis must be low, but can be present in infants. And complication need to be suspected, ensure adequate antibiotics. So our talk is morely on the localization. We are not going to details of the management. With similar case, this is again a case B, which is a 3-month-old child. So this child was having a recurrent, after the initial presentation, the child had a recurrent focal seizures, hypotension, rigid left-sided weakness. Child was having a neck stiffness, which usually tells you of meningitis. So you have meningitis plus you have seizures, means you have a meningoencephalitis. So usually we suspect a viral encephalitis, but certain bacteria may have, if the child is having a toxic look, which looks like a bacterial one, and if you have a history of pharyngitis, the cause can be a pneumococcal one. So there are certain virulent strains of the pneumococcal which may cause an active parenchymal disease even in this post-vaccination era. So that is something which is very important. You must keep an attention. So usually the toxic look points towards the toxic pathologies. And if you have still focal seizures, focal deficits, it is a pointer that it is having a complicated meningitis. So that is specifically occurs with the pneumococcal or subdural or the H influenza, where the pneumococcal may have an active parenchymal disease and H influenza pneumococcal both can cause a subdural collection. So these are the two complications of the bacterial meningitis. You should be aware and keep a low threshold on repeating an MRI. So because these symptoms might develop during the course of the event. So if your spikes are not coming down, you're treated, you did an LP, you started the antibiotics, but what's wrong with the child? So it may be a collection of the subdural empymas, or if you have a parenchyma which is involved where the antibiotics are not reaching, and that's the reason why the child is having a persistent neutrophilias or a persistent fever spikes. Keep a low threshold of repeating an MRI. So this is another child, 6-year-old seizures with the left-sided weakness and CRP more than 300. And what do you see here? So you can see a subdural hematoma here. So subdural basically an effusion, so which turn out to be a pyogenic later on. So these are very common. Can you see that? So what you're going to do? You're going to do a MRI or CT with contrast. Especially occurs in ABM, most common with streptococcal H influenzae, but its incidence is quite lower down. But there are still certain strains which you may get this in the clinical practice. So any persistence of fever spike, appearance of neurodeficit, signs of raised ICP, always think of complicated meningitis, especially if you are toxic look. And neuroimaging is something which is very crucial in knowing what complications is setting. Let's go to a gray matter disease or the active parenchymal disease. So this is an 8-year-old male child with a high-grade fever since 4 days, vomiting since 2 days, and extreme irritability since 1 day. Developed a focal convulsions in the morning, aborted by midazolam, but deterioration of the sensorium which occurs after 24 hours. Now responding to pain, no signs of meningism. So what are your differentials? So this child just had a high-grade fever with irritability and then the seizures. So fever followed by a little sensorium, which is gradually progressive, and the seizures are focal seizures. What does it tell? It tells you a likely focal cortical pathology, because seizures are the irritative manifestation of the gray matter. So cortical gray matter may usually have a focal seizures. Presence of fever suggests an inflammation. Acute presentation suggests a probable inflammatory pathology, probably most commonly an infective one, which we should think of. Then the second thing what you're going to look after, if such cases come first, what is the anatomical localization? We localize it to the focal cortical. Then I told you, when you want to set up a pathologies, what could be the important thing is a syndromic approach. What is syndromic approach? Look for whether the extrasystemic manifestations are there or only neurological manifestations. Like if you have seizures, altered sensorium, neurodeficits, or raised ICP, these are all the neurological manifestations. If you have a skin, if you have a shock, if your pancytopenia or any cell lines which is going down. So these are the extrasystemic manifestation. So look at the child. If the child is only having a primary CNS infection, it's likely to be having a affected by a primary neurotrophic virus like JE and HSV. So if your differentials, if it doesn't have an extrasystemic feature, your differentials are very tailored, we narrow down to JE, HSV. So what you're going to do? Will you start acyclovir? Yes, because your differentials is HFC. Will you go for cranial imaging? Of course, because that is something which is going to tell us. If you did an MRI and it shows, so your suspicion is HSV, okay, because it's a focal cortical pathology. And you did an MRI, but MRI shown a basal ganglia pathology. Will you continue acyclovir? So acyclovir is not required if there is involvement of basal ganglia, thalamus or brainstem, as the chances of HSV is very less. So this is how the syndromic approach is going to help us in managing the cases. I will make it more clear. So AES with the systemic features, like if any child having a seizures or this type of symptoms, if they have a rash or myalgia or low platelets or shock or hepatic or renal involvement, etiologies are tropical diseases like cerebral malaria, scrub typhus, dengue, chikungunya or leptospirosis, which are very common viruses and bacteria in our country. So what you're going to do, you're going to send a sample for malaria, doxycycline, ceftriaxone. Will you send a HSV PCR? No, because HSV virus do not have histrosystemic features. So you will use those resources in sending a CSF PCRs of those studies, because a lot of these things are not covered in the usual PCR panels. So MRI brain indicated, yes. Serological test for J indicated, no. HSV, no. So will you start acyclovir? No. So this syndromic approach can significantly reduce your diagnostic and the treatment cost if you go a little systematically. So what is the lesson learned? Fever with seizures or deteriorating sensorium, make a diagnosis of whether it's a very fast deterioration or very slow. If it is a slow, likely to be in focal cortical pathology. If it is a very fast, it has to be a deep cortical one. So syndromic approach is very helpful, not only in localization, but deciding the management strategy. And always remember about the purotropic viruses, which are very less, like HSV or J. At least this much the pediatrician must know. Let's go to third case. So this is an 8-year-old boy with a headache, vomiting, left focal seizures. The similar presentation to the earlier case. Seizures recurred, which diagnosed as a viral encephalitis, started on ceftriaxone acyclovir, considering it has to be an HSV1. Initially responded very well, did very well, then sent home. On day 10, came with abnormal behavior, restlessness, screaming, and violent behavior. Child was on oxcarbazepine and phosphonitoin, which they have continued. The child was having little drowsy, recognizing parents, clear, intermittent, irrelevant talking. Rest of the examination is normal. What's wrong with the child? So the child was treated with considering it to be an HSV encephalitis, diagnosed as HSV PCR. So what could be wrong with the child? This is what, if the child is deteriorating after initial improvement, what could be the pathology? It can be an untreated etiology because HSV virus requires a 21 days of IV antibiotic. If you stop it early, though if an initial improvement may deteriorate further. Second, it can be an untreated pathology or newly set pathology, like viruses have damaged the cells and it had exposed the antigens and it lead to an autoimmune kind of process. Third is drug induced. So carbamazepine, oxcarbazepine specifically they can worsen the encephalopathy. It's because of drug-induced one, autoimmune process has set in, or it can be a non-convulsive status because the child has initially presented with the status, and then it may be a worsening one because of oxcarbazepine, which has led to a non-convulsive one. So this can be the possible differentials. But what is more likely? More likely to be an autoimmune encephalitis, which usually presents with the oromotor dyskinesia and like that. So when you should suspect an autoimmune encephalitis? If you have polysymptomatic syndrome associated with the encephalopathy, seizures, movement disorder, psychiatric disturbance, or the gait disturbance of the autonomic features, you may have an autoimmune encephalitis. But do these all symptoms need to be there? No. You may have purely psychiatric symptoms. There are a lot of patients you are getting in this published in psychiatric journal where initial acute encephalitis and then followed by a sudden onset of irrelevant talking or hallucinations or so many symptoms and turn out to be anti-NMDR positive. I think this can be what is the most common? The polysymptomatic way. What are the strongest points that suggest an autoimmune process? One is oromotor dyskinesia. If you have hemifacial-brachial dystony, one-sided. If you have catatonia, the postures of the limbs remain fixed. If you have flexibly, your limbs look like a wax. If you have behavioral issues, sleep disturbances, dyskinesias, then it's likely to be an autoimmune. So we did an investigation. It shown an EEG with a slowing, with a so this is anti-NMDR encephalitis looks like. So usually have a first peak which goes down, improvement, and then another peak. with the psychiatric symptoms, with the prodrome, initial prodrome, and then psychiatric symptoms, rapid speech loss or seizures or movement disorder. So that's how the autoimmune presentations do present. So treatment is steroids, IVIG, and everything you know. So we have seen the first case of HSV encephalitis. So initially we have seen the meningitis part, complicated meningitis. Then we have seen the cases of focal cortical pathology like HSV. Then another pathology, which is again a focal cortical. It's the autoimmune encephalitis, but they have a different course. How do they present? So always monitor your patients of AES even if you diagnose an etiology. You have suppose HSV positive, still it can be an anti-NMDR1 because that goes into an anti-NMDR1. So always look for a new neurodeficits, raised ICP, new symptoms, look at the fever patterns and stop labeling these all conditions as post-encephalitic sequelae, which we used to do 10, 20 years back. So because and we must all know hallmarks of the autoimmune encephalitis. Let's go to another case, which you're going to localize at a different part of the brain. This is a 6-year-old boy coming from the monsoon season, coming from Bihar. So this is very important, sporadic or epidemic. So coming in an epidemic fashion, high-grade fever, similar cases in the vicinity, GTC, very bad deterioration of the sensorium in 24 hours. You remember your cases which are getting very fast deterioration in 24 hours, next day got ventilated. This is one of that case. But the patient is drowsy and there is a continuous intermittent posturing which is happening. HB, MP absent and similar cases in the vicinity. What could be the possibility? Will you go for etiological one? No. Approach dissection of the symptoms. Seizures tells you irritation of gray matter. So it has to be irritation of gray, cortical or deep. It can be in compression because child is having a raised ICP, but there's no vomiting. So localization goes to a gray matter. Rapid deterioration of the sensorium and then very bad deep altered sensorium. What are the anatomical localization of this presentation? It has to be one of the three. One, it can be a bilateral diffuse cortical lesion. It can be a bilateral basal ganglia or thalamic lesion, or it can be a brainstem lesion. But because if you have a posturing, you don't have a low motor signs, you don't have a raised ICP, you don't have a very active seizures, it's likely to be a basal ganglia pathology. And that's how we need to diagnose. So this is like localizing to the deep gray matter. So what are your pathological diagnosis? It's an acute presentation, likely to be an infective one. Persistent fever tells you inflammatory pathology. There are no extra systemic features. There is a bilateral basal ganglia or thalamic inflammation, which will come to an anatomical diagnosis. So if you have a relatively preserved markers of inflammation, that means there are no extra systemic features. If you're in epidemic cases, it's likely to be in probable arboviruses. And specifically, if your relative preserved markers of inflammation with a dense encephalopathy, without multisystemic involvement, with no progression of seizures, it's likely to be an arbo. And what is the most common in our setup is JE. So you can just make a diagnosis of probable JE on the basis of just history. We have not done any investigation till now. So this is the second region which you're going to localize, I told you. So this is how the JE classical presentation look like, and you must be aware of it. Similar case, 3-year-old, fever since 2 days, a very again rapid stormy course with posturing. But here, it's not a purely neurotropic symptoms. There are in addition shock, platelets, SGPTs, transaminitis in the order of 1 to 1200 or 1870 extubated on day, slow recovery. What is this? This is acute necrotizing encephalopathy. Can you see those bilateral thalamic hyperintensities? Can you see that? So this is again a close differential of JE, almost looks similar. If you don't provide all these details to your radiological colleague, they may report it as a JE. And the treatment of JE and treatment of this NEC is altogether different. It's the immunomodulation here. So why we should know about this NEC as a pediatrician? Because it looks like JE, can be misdiagnosed as JE, but this is an immune-mediated phenomenon. This is an IL-6 mediated injury. What is the clinical clue? It's transaminitis. And what is the treatment? Is immunotherapy. As I told you, the treatment is totally different. You are not going to start an immunotherapy if you are with JE. And if you're going to have this thing, the drug of choice is tocilizumab because it's the IL-6 mediated blockade and start a methylprednisolone as well. So, dramatic alteration of outcome can happen. So if you tell me 10 years, 15 years back, this I would have said the child is not going to have a peaceful life, is going to have a lifelong dystonia. But because the understanding of these immunological disorders are getting clear, we can safely say there is a drug which we should start within 24 to 48 hours. And if it started early, it can have a radical change, alteration of the outcome. So that is something which we should be aware of. So primarily, it's a cytokine storm which lead to a necrotic thalamic lesions in the setting of acute febrile illness, which is a hallmark rapidly progressive encephalopathy, and you need to start a very early immunomodulation. Because one-third have mortality, two-third may have significant morbidity if you don't start the treatment. Similar presentation. So this is another one. It's where you have fever, seizures for 4 days, encephalopathy, first MRI normal, CSF is normal. After 3 days, sensorium is improving. But on 8th day, again worsening of sensorium, posturing ventilated. What's wrong with the child? We did an MRI. And can you see those MRI patterns? So this is like a branching T pattern. So this is the ALERD. So these are again a clinico-radiological entities, and you can't diagnose these entities unless you have an MRI film. Again, the drug of choice is methylprednisolone, so you must be aware of this entity. Let's go to similar another case, which has a little different presentation. So this is a fever since 10 days, reduced activity, speech slurring, and swallowing difficulty. What is my observation about the pediatric way of assessment is we often see meningitis, signs of meningism, signs of raised ICP, posturing, and this, that, but we don't look after the movements, the correlationship between the consciousness and the movement. If you're getting conscious, but your movements are not improving the way it should improve, if you have the paucity of the movements, if you have bradykinesia, if you have rigidity, if you have tremors, this is often missed by the pediatrician. Though it is relatively less, but this child has presented with those symptoms and is diagnosed as acute Parkinsonism post-viral. We did an MRI, and what does it suggest? It's a bilateral caudate and can you see those basal ganglia, which is a very hyperintense, a very defined territorial lesions. So why this is why it is localizing? Because dopamine receptors are very high in this part of the brain. And this is a specific autoimmune encephalitis, this anti-DR2 antibody encephalitis, which looks like exactly, this is a classic picture of the anti-DR2 one. So if you start a IV methylprednisolone very fast in this subset of the child, there's a very good recovery. So what is the lesson from this case is hypokinetic movement disorder should be carefully observed, often missed, and look for the extrapyramidal movements like tremors and this, that in every single child during every single day. Ask him to do so whenever the child is improving, even if they are improving, just look at those symptomatology. So in a deep gray matter, we have seen 3-4 cases. One thing was a prototype JE case. Another is the NEC case. Fourth is the Alroid case. And fifth one is this anti-DR2. Let's go to the different part of the brain. Now, this is a 4-year-old girl with fever, vomiting, altered sensorium. But on examination, there are reflexes of brisk and restriction of the left eye movement. So any child who's having a motor deficits, which are asymmetrical, which are developing the setting of acute encephalitic syndrome, where you will localize the lesion. So the localization goes to white matter. Why? Because focal neurodeficits, if you are asymmetrical one. So if it is symmetrical in a defined territory, suppose I'm getting a hemiplegia or a monoplegia, you may call it as a vascular territory. You may call it as a stroke. But if it is a polysymptom, here deficit is in the right upper limb and the lower limb and there's some restriction of the gaze or something. So if it is a asymmetrical polyfocal deficits, it has to be a polyfocal white matter pathology. And that's how the edema looks like. So this is a classical MRI of the edema where you can see this is a multiple white matter hyperintensities, which looks like cotton wool. It doesn't have a very good defined borders. So it's look like a cotton ball, which are present polyfocally. So this is edema. So as I told you, manifest as neurofocal motor deficits. Paraventricular fluffy opacities may involve deep gray matter. So it's primarily an acute febrile illness with encephalopathy, pleocytosis, increased proteins in our case, multiple white matter brainstem lesion. They can present cerebellum as well. And the treatment again is methylprednisolone 30 mg per kg for 5 days. And you all know the rest of the thing. So I'll not go into much of the details of how does the do present. So so the third part of the brain is white matters, which usually have demyelinating lesions. There are lot many new conditions like MOG antibody associated or NMO. We'll not go into the details because there's a short of time and I can't speak to that extent because it's beyond the scope. Let's go to another part of the brain, which how does it present? So this is a 14-year-old girl, fever with since 3 days, but has a hyperacute onset drowsiness, difficulty in walking. But the child, end of day one, child is comatose and ventilated. No motor responses, no breathing efforts. On an examination, is a profound flaccid quadriparesis. So usually if it is a flaccid quadriparesis, you localize as a GBS or something. But if it is an associated on hyperacute onset drowsiness, usually get confused whether it's a UMN or LMN. So this is how they do the present. So if in addition, if they have a cranial nerve deficits, where are you going to localize? So this is something called as a brainstem encephalitis. So hyperacute drowsiness is a third differential. You have seen the cases of acute one, where you see the cases of hyperacute course. The second one is for the brainstem, and third is the basal ganglia. So here we had a weaker stop brainstem encephalitis. So this is how the brainstem encephalitis look like. So this was positive for GQ1 antibody, which do they present, and later with the started of immunomodulation, IVIG and methylprednisolone, the child started walking. But if you get such cases of rhomboencephalitis, like a acute profound hypotonia with a flaccid quadriparesis with the deterioration of sensorium, what are the important causes? Are the enteroviruses? Don't forget rabies. We have burnt our fingers. We have seen a case of rabies, which was attended by almost 21 days later. We got a history of dog bite and it turned out to be rabies. It can be adenoviruses, it can be autoimmune or inflammatory pathologies as well. So lesson learned, rapidly progressive deterioration of the cranial, deterioration of sensorium with cranial nerve deficits suggests a brainstem involvement, specifically with the quadriparesis. So we all know with the rash, vesicular rash, maculopapular rash, we may have different presentations of the disease. And this is the last case where the lesion, now you please write in the chat box if you're attending and listening carefully. This is an 8-year-old male with a headache since 1 week, neck pain since 1 week, drowsiness since 2 days, decrease in the world output, fever 1 week back. Child is conscious, oriented, but child is mute. Vertical and horizontal nystagmus is present. Torticollis to the left, ataxia. Where you will localize? Because the ataxia is present, torticollis or the nystagmus is clearly likely to be a cerebellum because child is ataxic as well. But child is having mutism. Can only a cerebellar pathology look like mutism? Or it can be a Broca's area or some part of the white matter and the cerebellum? Still it can be. It can be an edema because these are all the motor deficits which are happening. So we did an MRI to look after. There are no patchy apparent densities like edema. So this is not edema. But what is this? The cerebellum is totally swollen. So this is a cerebellitis. Cell counts 200 cells, 88% lymphocytes, 12% neutrophils. Proteins are 92, sugars are 49. So can you see? So have you looked at how the cerebellum is tightly packed below the tentorium cerebelli? And this is how very snugly fit into the posterior fossa. And if your cerebellitis, there's inflammation and the swollen cerebellum, then you will have a crowding of the space. So it's a life-threatening condition. So usually a lot of people give IV Dexapod or leave, or they give, a lot of people also tried IV oral steroids also. Don't do that. Admit the child, look at the conditions, look at possible signs of tonsillar herniation. If it is because it's a potential life-threatening condition. Usually it's a viral etiology, post-cerebellar ataxia, and this is very common. Symptomatic treatment is something which is needed, but it suddenly can lead to a tonsillar herniation because there is no space that the cerebellum can expand its terrain. Usually the rotaviruses, varicella zoster, EB are the more important one which do they present with the cerebralitis. So what is the lesson learned from today's this thing? Cerebralitis can be life-threatening and you need to. So we have seen first cases of HSV encephalitis, the focal cortical pathologies, HSV and the autoimmune. Second is the deep gray matter pathologies like JE or NEC or the ALRED or the anti-DR2 encephalitis. Third, we have seen the cases of edema or the demyelinations. Then we have seen the cases of bigger stuff encephalitis, the brainstem involvement, and then we have seen the case of cerebralitis. This is how the symptoms and this is how your approach from anatomical diagnosis to pathological diagnosis and the etiological diagnosis. Having said that, what I feel what is important, because don't label any cases of acute viral encephalitis unless you have a documented thing, because viruses are very notorious. Viruses not only do an injury to the brain, but also it can trigger demyelinating process. So that should not be missed. It can decompensate IEMs, because I have seen in government medical colleges, everybody is looking after the child as the 6-month-old child admitted with acute encephalitic syndrome. Everybody is sending PCR and this and that and whatnot, but nobody's looking at the head size of the child. So, but if you have a macrocephaly, that's the Canavan, turn out to be a Canavan disease. So don't miss those clues of the IEM, which usually if in infantile period, if you are with the every viral infections, the patient is going very down, regression of the symptoms. So don't miss those, because viruses are very notorious in decompensating the underlying IEMs. Third is a viral triggering an autoimmune process. So usually HSV1, which goes into an anti-NMDR1, where you are little biased with having a diagnosis of HSV PCR in your hand, and then you often miss those autoimmune processes. Fourth is viral precipitated non-convulsive status. So child is having an unexplained encephalopathy after initial status like presentation. And if you don't have an EEG, so that's the very gray area where you are likely to miss this electrical non-convulsive status, and you need to do an EEG. And that's how our ICUs need to be equipped with EEG and well-known, reported from the well-known pediatric neurologist. Then only you can diagnose these conditions. And the fifth one is viral induced vascular insult. So suppose the child had a dehydration, you're treating as acute encephalitis, so you're treated that thing, but the child may have a secondary cortical venous sinus thrombosis. So acute onset of paraplegia, if you don't look at it, so it is likely to get missed. So that's how we should not miss this viral insults. So thank you so much for kind attention. I felt that I don't know what as 45 minutes was given to me. I don't know. So I tried my best to cover the topic and give you a bits and pieces of the varied scenarios. How do the acute encephalitis acute encephalitis syndrome presents in childhood? So as a National Secretary, I thank you so much for being attentive. And as a National Secretary of Academy of Pediatric Neurology India, I invite you for our 25th Annual National Conference of Academy of Pediatric Neurology. Earlier, we used to call it as a neurology chapter of IAP. Now it is AOPN India. So Neuropedicon is 2026 is going to be there very near to you, Lucknow city. So I invite you, all of you, for this academic fest. So this is a 3-day program from 23rd to 25th of October 2026. Please block your date and register this conference. Thank you so much. And thank you once again for the opportunity. Thank you, Praveen sir.
No, thanks a lot. Thanks, Dr. It was such a wonderful presentation. It was really mesmerizing. I think you put all the things beautifully in a very small span of time. It's a big topic. So all the kudos to you. I really like that part that I mean, we need to have a very good account of the history to really delineate what is the localization. And as you mentioned that we all should have we all forget about the anatomy after the first year. Need to go back and learn about the basics of the new anatomy to really categorize which I mean pathology it can be affected. I mean, even with the advent of our different neuroimaging MRI techniques, before even we get the MRIs, we already have got the thoughts in the mind. This could be possibly these viruses, as you beautifully, I mean, uh, told in your clinical presentation only on the part. Uh, that's why interesting. Now, there are a number of cases which can have absence of meningeal signs. So as a practicing physicians, we give a lot of value to the meningeal signs, but they can be meningitis without having the meningeal signs. That is something which we all have to keep into our mind, that we should not disregard meningitis unless until we're finding the meningeal signs in that way. We have come across those couple of those pneumococcal cases which were really, really kind of, they always leave you with a kind of like brain scar in
Correct.
the
Very, very
brain.
bad catastrophic conditions.
The thing which we really worry, like an herpes. Yeah, so like whenever we come across like herpes encephalitis, that always leaves a kind of like bad scar. The same goes along with the pneumococcal also. And many times we find that whenever we find the child coming with acute meningitis, having significant papilledema, so we think this could be possibly a pneumococcal because you don't get, that's my personal experience. I would just like to share with you, and I would like to invite your opinion also, that we don't get papilledema in the meningitis unless this is something like tubercular meningitis. Or or what I have found personally is this, that pneumococcal. Pneumococcal is the one meningitis where you start getting papilledema in the fundus examination. Tuberculosis is very, known to cause, and couple of patients which I recollect, they all had this part. And the second is definitely about the low CSF sugar with the pneumococcal, which we see with the tuberculosis
Correct.
meningitis. And possibly, I think this is something with the inflammatory. Tell me that, are you finding something different kind of like epidemiological pattern in your place, like in the Maharashtra and those ones with the encephalitis? These days, or
Yeah, that's the reason what I said, that we need to have an anatomy first. We need to diagnose it anatomic, what are the probable areas which should have been involved, and then do a radiology. Usually, there is a rising trend among the residents and even the pediatricians. They go for an MRI first and then they diagnose the condition. I think that practice has to be strongly discouraged. I tried my best to give this thing that you diagnose it first, we think of the differentials first, and then come up with this thing. The second query, so that was a very good point what you raised. Second thing about the epidemiological distribution. So there's a wonderful paper on it, which talks about, so there are a lot many people like Dr. Pratibha Singhi madam and everyone across the country, Dr. Vinan and everything. So they talk about, because the patterns, the epidemiological pattern is so different, because the geographic terrain of the country is so wide and spread out, that the causality in the Kerala and the causality in the Bihar, causality in Maharashtra and Delhi is totally different. So we need to develop a regional specific algorithms, because people always ask you, okay, you are told everything, but then if the patient comes to us, what we need to start? Should we start acyclovir? Should we start this ceftriaxone, or should we start azithromycin or doxycycline? It all depends on the patterns what you get. So look at the patterns, sporadic or epidemic, if it is an epidemic one. So especially what the question you asked me, what is more common in Maharashtra and what is different than this? So we see a lot of rickettsial encephalitis, rickettsial encephalopathy. Dengue is of course so common. I think you may have a similar representation of dengue. But then apart from this, we have a lot of rickettsial encephalopathy, because especially in this Western Maharashtra and this Parbani and this Marathwada, what we say, Marathwada, Vidarbha, we do a lot of cases of this thing. We also see the cases of Jabbi also, but they're not common as Uttar Pradesh and Bihar. But yes, we have a rice paddy field, the districts of the Vidarbhas, which Bandara, Gondia and everywhere. So there's a rice paddy field. So we get a lot of cases of JE virus. So having said that, the JE and the NEC, a lot of cases of NEC are coming up. A lot of cases of autoimmune encephalitis. There's all patterns. We usually, when we used to attend the international conference, we used to feel that these are the relative entities and we don't see that. But we see a lot of NEC. I don't think we have published, we are publishing this thing, I don't know, 45 cases of NEC in last 2-3 years. So that's a pretty good number. And the best part is that we can change the outcome. If you start aggressive immunotherapy, if you do a little fast MRI, if you start those tocilizumab very fast, it changes the outcome dramatically, because it's better to hit it fast and start the immunomodulation rather than to wait for the MRIs and then thinking of some condition, then starting tocilizumab on day 8 and day 10. Don't do that. So, and the third part is very important. I think there's a question also on this. What is the text available for localization symptoms? I think we have developed with, I think the Praveen sir was also part of that. IAP and the neurology chapter, AOPN, we have formulated the guidelines also, and we have formulated an entire module on acute encephalitis syndrome. Earlier, it was launched during Dr. Vasant Karatkar sir tenure as a EASE module. Encephalitis, there's a separate module, a dedicated whole day program only on the encephalitis. I think that is worth reading because a lot of people have spared, means it is in collaboration with the infectious disease chapter. Dr. Sanjay Gorpade sir, Minash, everyone was there, and they were, and the very Dr. Vijay Avle sir, Dr. Nitin Shah, all the expertise of the neurology and the infectious disease chapter sat together. We had 20 Zoom meetings on the basis of which we formulated. Then we released. Then we had so many meetings has happened. I think Pradvin sir was already there. He knows the thing. So it came out very well. And now we are again working to materialize this into a guidelines one. I think that is something which you should be, this will be available in the guideline form soon. But if you want to attend, if anyone want to do this thing module, please contact us, especially Praveen sir. Praveen sir is there, so he is our man. He is the secretary of the AOP in Delhi state. I take a lot of privilege to say that. And he's very supportive. And as I told, he's the elder brother to us. So whatever he says, we listen to him. Thank you so much.
No, that's great, and that has come out really well. I mean, you mentioned about that the guidelines, it has come really well, and I think last I mean 5 years back we also had our own study on the acute encephalitis syndrome, and as you mentioned that it differs from the region to region. So what we found was the most common etiology in our group was the autoimmune encephalitis. And we had a study from the different government sector in the Delhi itself, and there are different kind of like pathology. So even in the same city, we can have a different kind of like pathology coming
Mm.
from the, depending upon what patients are coming to you. So we'll just take a couple of questions, Dr. Vineet. Just let me, I think you already answered about the which text, and that is the beautiful text. They all should go and they should come and attend this part also. Should all post-viral encephalitis be admitted? This is, yeah,
So I already answered that. So you must keep a watch. Please
yeah.
admit those children. Look at the signs of raised ICP. Please monitor those child because this do develop the probable tonsillar urination. We have seen, we have burnt our fingers. People have seen, people have also shared with us that this has gone very bad. And then what likely to be a very benign syndrome, it turned out to be a fulminant one and a very bad or catastrophic one. So please look at them very carefully and explain them why we are admitting the child. Though they look initially normal, but if at all, so if the symptoms are declining, everything is getting okay, you can discharge the patient. But please monitor, admit the patient and monitor the progress.
Yeah, I agree. In fact, I remember that we published that case also, one of the cases where we had to do the posterior fossa decompression after third day of
Correct,
admission to a girl who
correct.
had come back from the Shimla and got the cerebralitis part. So totally agree that must be admitted and monitored for the initial couple of days before we see that the process is over. Then we have got another question. Can viral infection precipitate neurodevelopmental disorders?
So the neurodevelopmental disorders are a big chunk of baskets where if you specifically, I want to tell the neurometabolic disorders which lead to a neurodevelopmental problems, like specifically I talked about it during my last slide. There is a lot of decomposition which happens because of the viruses, because they are intracellularly affecting the thing. And so they disturb the metabolic cycles. So, and they leave that impact on the child, even if they improve that stays with them. So that regression stays with them, and it take another months or weeks or months or so years even sometimes to come out of that viral infections. So those subset of patients who have viral neurometabolic causes, usually they do have such precipitation. In addition, there are certain genetic channelopathies. There are a lot of genetic conditions which there are a lot of neurodevelopmental disorders which has a genetic etiologies. Specifically, those channelopathies, do they have a viral precipitation? And they do deteriorate with the viral infections very badly. I don't, Praveen sir, you can also say a few things
Yeah,
about
I
it.
think I totally agree. In fact, whenever we have something like which is going, which is taking more time to recover after viral infections, we must look for those energy or metabolic defects, which takes that you're taking much more toll on your body. So that also has some mitochondrial disorders or those metabolic disorders which can go down with the viral infections. So the answer is yes, as you said, Dr. Vineet. Last, I can't read fully, but they say that one of our attendees has mentioned while checking neck stiffness but not stiff, is it significant?
I
So
think question
I
is
can't read
the child is frowning and not having a this
no
thing.
problem.
uh, but not
Yeah.
while checking a neck stiffness and doesn't allow, then whether
Hmm.
it's a significant or not. So neck stiffness is a typical sign. Frowning is something, a symptom which is like the child is making and this thing. So to look at the neck stiffness, which is very important. Earlier, we used to get a very so neck stiffness of the acute bacterial one and the tubercular. So earlier, our teachers used to teach us how it is different. And the tubercular neck stiffness, the way that it's so rigid and then don't allow. So that is because it causes a lot of basal meningitis. So it stimulates those all nerves and lead to a very bad stiffness. So you can differentiate on that, but because the tubercular meningitis is so declining rapidly, we hardly see this. I don't know whether it's in Delhi, so that common. It's very less in our setup. I have seen almost a year, sometimes a
So
year
I think
passes, we
we
don't
see now
get
more of
the
MDR. So we are
huh?
seeing, yeah,
TVM still
so we
see.
are seeing a lot of MDR tuberculosis. We are seeing a lot
Okay.
of multi-drug resistant tuberculosis these days. So I think it has also taken a different kind of
We're
life
very
trajectory,
fortunate we
and we
don't
are
see that.
finding, yeah.
Even
So
if we
to, I mean,
train
today
the
only
crowd
we have
of the
got three
MPs
cases
and
with
this thing,
the,
what I felt is post-COVID with the mask and this thing, I think what has first declined is tuberculosis dramatically
okay.
in our setup.
Very good. So I agree
Should we
possibly that we
continue?
look for the true medical science and not for the frowning partner. So I think that that finishes our questions, Dr. Vineet. And again, it was a very lucid, wonderful, very insightful lecture, and I'm very sure that all our attendees all across India, they must have benefited immensely from your lecture. Even I really, I mean, truly enjoyed listening to you as
Thank you.
always, full of
It's
messages and very
it's a
crisp
privilege and honor for
messages,
us.
practical tips.
Thank you, sir, for those kind words, and thank you everyone for attendance. Thank you so much.
Yeah, thank.
Should
So
we
we need,
conclude?
yeah.
Good
So
night,
if there no,
everyone. Good night,
I mean, no other questions, I think you are also, yeah. So thanks a lot, Dr. Meet, for taking out time, and we'll meet again with some new class, some new topic, and to
thank
listen to you.
thank you
Okay.
so much. Thank you so much.
Thanks a lot. Good night.